Unfortunately, it's on almost all aspects we're behind. Even chronic conditions that you would think. So, for example, female cancers, we're far behind in the research for female cancers as compared to male cancers. Conditions such as heart disease for females, all of the education, all of the science, all of the research has been done primarily on male patients. The textbooks are all on male models. The training is all on male models. So even things that we think we know a lot about, heart disease, we know that, we've done that, we know what the risks are, but there's still training, there's still education that needs to be done. Even as simple as how a heart attack presents in a woman compared to a man.
Hello and welcome to another edition of the Health Beats podcast, brought to you in association with Abu Dhabi Global Healthcare Week. My name is Steve Gardner, Managing Director of Healthcare World magazine, and I will be your host for another great conversation. If you've not already signed up to the podcast, make sure you subscribe on Apple Podcasts or Spotify, wherever you get your podcasts. We've had a whole series of fantastic conversations, fantastic discussions on Health Beats over the last few weeks, and today is no exception. I'm joined today by Dr. Summia Zaher, who is the Chief Executive of the Dana Al Amrat Women and Children's Hospital in Abu Dhabi. Somebody I've had the great privilege of meeting and sharing a stage with before. We were involved, weren't we, Summia, in a great conversation back in January about women in healthcare leadership, and I wanted to follow up on that today. As I always do, Summia, if you could start by just giving us a bit of your background, your journey, because I think you've had quite a fascinating journey to where you are today.
Thank you, Steve, and it's lovely to catch up again following our short but brief time, but in January. But yeah, no, always lovely to catch up with you again, Steve. A slight add-on from the title of Chief Executive Officer of Women and Children's Hospital. Role has actually expanded a little bit more now to being Chief Executive Officer of Women and Children's Care Cluster for all of M42, which now includes the National Emirat Hospital for Women and Children and Health Plus IVF. And I wanted to add that in, really, Steve, just because it's a demonstration of how rapid and the trajectory that my career has kind of been on since arriving in the United Arab Emirates. So we're going to rewind and go back a little bit, because exactly like you said, my journey has been fascinating to me, and certainly to my family, I'm sure. I was born in Manchester in a family of doctors, to a family of doctors, and one of 7 children. I have a twin sister, and both born to both parents doctors, their Egyptian background. So born in the UK, with obviously a Middle Eastern background. I was very quickly recruited into the family business. I started off kind of having the slight inklings of wanting to be a film star, and then a businesswoman, and then a teacher. But then actually...
And now you're all 3, right?
Absolutely. And it was actually my father who said, my first real kind of career that I wanted to be was a teacher. And he generally told me, look, you can be a doctor and a teacher, but you can't be a teacher and a doctor. And that resonated with me, actually. And
Wow.
So I did go into medical school along with my sister. We discovered the city of discovery at that point, which was Dundee. We went to Dundee Medical School and had an amazing time, actually, together. Went into medical school at quite a young age. Learned a huge amount, and I went into women's health. I mean, my father's a retired obstetrician and gynecologist, and I think really to prove him wrong, because he said it wasn't a career for a woman, I decided to do it. Because it was very intense hours.
Different generation, I suppose.
Absolutely. It was very much that. It was a very, very intense specialization, and generally kind of the theory was, try and choose a specialty that's a little bit easier on family life, GP, dermatology, that sort of thing. But But as usual, I'm someone who doesn't like to be put into a box. And I thought, well, I'll do that. Thank you very much. And so I picked that specialty. I had a wonderful professor of obstetrician and gynecology. And so kind of that's what took me into that career, really.
Yeah. So, I mean, firstly, I want to say congratulations. Obviously, this is the first time we've spoken since you got the promotion. So, really, really well done on that. It's also interesting that you know, and as you say, we didn't get enough time in Dubai. So, to be able to do this properly and take some time to have a proper conversation is fantastic. But you speak about your dad quite a lot and about your family and your upbringing. You know, how is that's been a huge influence in shaping who you are and where you've gone in your career, hasn't it?
Definitely, definitely. I think my cultural identity is very much the pulse, or let's call it the heartbeat of my leadership style. I think being a woman from the background, a Middle Eastern or the MENA region background, I think we generally have these values instilled in us from a very early age, and that's like responsibility, resilience, compassion, generosity, and community. And I bring all of those in my leadership style. But at the same time, I've also carried the responsibility of breaking barriers. And that's not just for myself within my family, but for generally the cultural expectations for women in general. And so I've had to kind of utilize those to turn it into strengths, you know. And so I've understood deeply and instinctively what it means to be a leader for women in this particular region, both emotionally, physically, culturally, and that insight has kind of championed the leadership that I display today.
And I've got to say, when we did our on stage in Dubai, my partner, my other half, was in the audience and thought you were inspiring. My daughter has since seen that video and also said that you were inspiring.
Thank
I
you.
mean,
That's lovely.
is that something that you think you've picked up because of having that kind of strong family background around you? Is there also an element, you know, being one of 7 kids, that you've kind of got to be a bit pushy and a bit forward just to be heard amongst the noise?
100%. I mean, let's say it this way: what I achieved going into medical school, getting the obstetrics and gynecology medal wasn't very special. There wasn't anything special in my family. I came from a family of doctors, all very high achievers. So there was always that kind of push that, you know, what next? What are you going to achieve next? So yeah, ambition was kind of injected into me very, very early on.
So very competitive family of
Definitely.
doctors. Obviously, you've ended up in a fantastic role in the UAE. How does that rank against the other 6? Because I'm sure you all compare your achievements, right?
I would like to say that I'm on top at the moment. I'm sure they'll I'm sure they'll
Tremendous.
say differently. We've got vice presidents of some AI companies and all sorts, but I would like to say, I would like to think that the impact that I have the potential of being involved in or doing is immense, and that's what excites me truly.
So talk us through the next step. So Dundee, the capital of culture and learning, and you know, basically the Scottish Riviera
Yeah,
of Dundee.
absolutely, absolutely.
Where did you how could you top that? Where could you possibly go up from Dundee?
So I met my husband in London. So that's kind of why I moved there to St. Mary's, which is a fantastic training. I did my research degree there. Look, I have this tendency where I looked at what boxes required to be ticked for me to become the most complete doctor. I never liked being put into a box. And so I didn't just want to be a good clinician. I wanted to be a good educator, a good researcher. So I did a doctorate degree. I did a postgraduate diploma in medical education. I did a qualification in leadership, clinical leadership. I really wanted to be an all-rounded clinician and come out with all of the skill set that I thought would be needed to really make an impact in the NHS. And I truly believed at the time when I started working. So I started working in 2001, and I've kind of done the whole England, Scotland, Wales. and ended up with my consultant post in Wales, and working in the largest university teaching hospital in Wales, in Cardiff, in maternity. So I kind of, once I'd made my decision to do women's health, I stayed with that. I didn't kind of change decisions about my specialty. I think I knew I wanted to do medicine, and I knew I wanted to be in women's health. So I started my post there, and just very quickly, I knew that there was changes that needed to be done. I believe that the NHS was the best healthcare system in the world. At that point, that was probably 2000, between 2008, 2010. And then as you kind of grow in the career, I became Labour Ward lead.
How was the experience of the NHS? What do you feel you learned from the NHS?
So I guess, having worked now in two healthcare systems, it's a good place to be able to compare both. And the NHS gives you that standardization, that security, the safety, the evidence-based guidelines, being able to offer patients standardized care. That's hugely, hugely important. Some of the obstacles is just the bureaucracy, the difficulty in making changes. And that's extremely frustrating for anybody that's got an ounce of creativity or innovation. And a lot of the extra or further learning that I'd done in my leadership degree, in my education degree, and the research definitely instilled in me that kind of creative bug, or that innovation, not taking no for an answer, or this is the way we've always done it, was not a good enough answer for me. It was like, well, why can't we do it this way? And I think making change in the NHS became extraordinarily difficult, lengthy, and frustrating. And that's kind of what led me to look elsewhere.
And looking at it now, obviously looking in from a distance, looking at what's happening with the abolition of NHS England, with what Wes Streeting is looking to try and achieve as UK Health Minister, how do you feel? What do you see? What do you think of the changes that they're trying to make to the NHS? Are they doing the right things here?
That's a difficult loaded question, but I think the right healthcare system is a fusion of both what we have in the UAE and what we have in the UK. There's no doubt that the UK kind of leads with the quality, the patient-centric models, but there needs to be financial injection. There needs to be agility. There needs to be a little bit of ambition and innovation, and scope to run with that. And definitely the NHS doesn't have that.
So do you think that's simply a question of the way in which the two systems are funded? The difference in funding creates a difference in culture?
Absolutely. And what I've tried to do here since arriving in 2023 is really try and create or marry the two healthcare systems. And I've been told as soon as I started, you can't do that. That will not work here. But it's been absolutely amazing, the reception that I've had from not only patients but the healthcare providers themselves, because there's been a lot of change in their practice, and it had to be relevant to the region. So I've had to be, and I think being from a Middle Eastern background, that actually was one of my strengths, in that I was able to kind of understand the cultural nuances, the sensitivity, and really be able to marry the best of both worlds.
So what elements of that NHS system, of that NHS way of working, have you brought into? What specific examples can you give you of things that you brought into the UAE from that NHS background?
So my first philosophy when I started was that no matter which doctor a patient comes into, when they enter this hospital, they should receive the same standard of care. And so the standard of care should be dependent on this hospital. When you arrive here or you come through the doors, this is the kind of care that you would get. That wasn't necessarily true, because it just depended on whichever doctor. Doctors would manage patients in different ways, depending on where they'd done their education. So I very quickly created guidelines, standards of procedures and policies, and said, we are all going to agree with this. we created a little stakeholder group, guideline group, and we agreed on it. There was a little bit of should we pick US guidelines, UK guidelines, and in the end we did a mix of the two, which was relevant for here, and considering the insurance background that we have here, considering the financial or the resources that we have, and this is something that everybody abides to. So we know that no matter they see Dr. A or Dr. B, patient that comes to Danat will be treated in this way, and that was really important for me. It shouldn't be a lottery. The care you receive is dependent on which doctor you have a chance to meet.
So from that standpoint, I mean, you said yourself, you're a doctor by background, a doctor who doesn't take no for an answer. Did you have any pushback or any difficulty with some of the doctors that you're sort of imposing this policy and structure on?
Lots, Steve, and it wasn't just from doctors, because one of the policies and actual tangible change that I managed to achieve, for example, and this is really important to me, particularly in my background as women's health. One of the I don't know. So an episiotomy is a cut that is made during labor, and that was a very high percentage here in the UAE, or in our particular hospital. It was at 45%. So almost 1 in 2 women who came to deliver would have an episiotomy, and that is purely because it's very interventionalist here. But also, if you think about it, we're in a very insurance-based model. So if you make a cut and you're going to sew it up, you're going to get more money. And so I had to move away from that. I said, that is not the correct thing to do. It's not the best thing for the patients. It might bring you a little bit more money, but it's not the correct thing to do in terms of the outcomes for these women later on. And so I had to educate the doctors. I had to educate the patients who thought, hang on a minute, I was told I have to be cut, otherwise I might tear. So there was education for patients, there's education for doctors, but there was also education for those that held the financial purses. We're going to see a drop in money, but this is the right thing to do. And I've linked in with the regulators, with Department of Health, and this has been a real success story for us. We've reduced our episiotomy rate to 18%, and we've presented this at many conferences now in the region and in the UK, actually, as a real success story, and it's something I'm very proud of. And it shows that you can change, you can make change when you're doing the right thing and you've got the patient at the centre.
That's an absolutely brilliant example, and it does. This is something I speak about a lot in terms of the differences between, UK system where it's free at the point of delivery. I think I once described the UK system as being the magic money tree, because no clinician ever looks at a patient and says, I can't afford to treat you, as opposed to an insurance-led system where there is this perverse incentive of do more things and therefore get more money. I mean, is that a prevalent practice in the UAE and in other insurance-led systems to think about things in terms of we will be more interventionist, we will do more stuff because the benefit is there to us? Absolutely. In financial terms? Yeah. How often does that happen?
Yeah, and it does happen a lot. And I think the Department of Health at the moment is becoming much more. I mean, it's a fantastic regulatory body, and I think initially the insurance-based model was aligning itself more to the US healthcare system, which is actually not the ideal. And now they are looking elsewhere, Australian healthcare systems, the UK healthcare systems, to try and merge the two. So the UAE has a mixture of both. It's got government-funded hospitals and private hospitals. So you will certainly find differing practice in government hospitals, so Siha hospitals here, compared to private hospitals, where there will certainly be a lot more intervention. But there are advantages to the healthcare system here, even to me as a clinician. For example, when I, in the UK, used to recommend to women a comprehensive approach to care, so physiotherapy, or I would like you to see a dietitian or a psychologist, they would have to wait almost quite often more than a year to see these allied health professionals. Here, I can give that patient that holistic, that comprehensive care in the same day package. And that's really, that's a big thing as a clinician, for me to feel that actually I've given my patient the full care, the full package, and so that's been a huge thing for me as well. So there are certainly advantages to the healthcare system here as well.
Yeah, it's a really, really fascinating one, isn't it? I mean, I suppose there's an element there of, as it's free at the point of delivery, the financial pressure comes in a different place and in a different area. And you've got a situation where people expect more. I mean, how much does that extend, for example, into primary care? You know, where in the UK we have the issue around access to primary care, people being able to get appointments with GPs and see a doctor. How does that differ when you're looking to get for that first contact with the healthcare system in the UAE?
So the primary healthcare system here is very primitive. There's the exciting thing is that that is changing in the UAE or in Abu Dhabi certainly, and we are looking. So I've been in talks with task force to define what that will look like, but we are looking to kind of build a primary care model very similar to the UK, so that there's that first point of contact. Currently, you've got patients who are having to navigate that healthcare system themselves completely. They have to know what's wrong with them and know which doctor they need to see, which can be a real lottery. And it's dependent on which doctor you see, whether or not they will look at you and think, actually, I'm not the right person, I will refer you to someone else, dependent if they're in a private setting and actually they've got some productivity targets that they need to reach. So they quite often keep patients to themselves. So it's a difficult and complex healthcare landscape, and trying to redefine that as we're doing here in Danat and within M42, where we're trying to push the message. Let's do the right thing. Let's become. Let's have quality with the good business model as well, and that will bring business to the region. But let's start with the quality, and let's start with doing the right thing first.
I mean, there's also a cultural element to this, isn't there? Certainly, I've heard stories in the past, and we're probably going back a few years now, whereby indigenous peoples from Saudi, from UAE, etc., would look at primary care doctors and think, well, a GP isn't a proper doctor. I mean, the standing joke used to be, what do you do if you've got a headache? You go and see a brain surgeon. Is there still a work to be done in terms of educating the public and socialising the idea of primary care and the GP as the gatekeeper of the health system?
Yeah, correct. So the GPs here are actually they're called family health consultants, which is actually a much better name for it, because I think calling it a different title gives it the respect and the understanding of what that role is. A general practitioner, I think, is a misnomer, and a family health consultant is the correct name. So you won't find the title GP here. So there is certainly a bit of understanding there for the public. There's a lot of education that we're doing, and that's again something that I've been pushing here. It's not enough to wait for patients to come to you. We have to go out to communities to educate, to empower patients so that they are in charge of their own health.
I think there's another interesting point about the way in which the Middle East in particular is changing. And from our previous conversation, sounds like it's changing rapidly in terms of the attitude towards women in healthcare. So from your point of view, both as a leader and as a doctor, have you, how has that been as a woman? Have you found that you've had issues being a woman in leadership in healthcare? Have you found that you've had any issues being a woman dealing with perhaps older male patients?
So I'm lucky in that my patients are all women. But I have to say, actually, the stigma or the general obstacles that you face in terms of a woman in positions of leadership, I haven't faced in the UAE. As much as in the UK. And I don't know if that's in the UK because I also had the added obstacle of being from an ethnic background, even though I'm born and bred in the UK. So I guess being a woman and ethnic minority, that was too much for some, because I often faced, I mean, the usual skepticism that I'm sure many others have faced. Are you the doctor or are you the nurse? Are you actually going to be doing my operation? Being quite often the only woman in a room, or being told you look very young. I haven't faced that here, and that's been one of the real attractions for me to moving to the UAE. Was I have a young daughter, and I really wanted her to feel that any career is open for her. Any career is open for her. And in the UAE, you truly have women representing in all sectors: engineering, science, technology, you've got astronauts. So it's amazing. And what I've loved about it is you will see women in their full abaya, fully covered up, and they haven't needed to give up their femininity for their roles. It's not a one look that needs to fit all. You don't need to put on a suit, or you don't need to look a certain way to be a leader. So that's been really lovely. That's been lovely.
And it is. I think that this came out of our conversation in January. The thing that was most shocking to me, in the whole conversation. I mean, there's two bits really in what you just said. I mean, the idea of somebody turning up to a consultation anywhere in the world, looking at a female doctor and saying, "Are you the doctor or the nurse?" That's just an indication to me as a liberal male, of just how shocking the treatment of women can be. I mean, that's outrageous. But the really, really shocking piece to me was actually how much further ahead the Middle East is as opposed to the UK. I think it's the opposite way round to the way that most people would expect it to be. That actually it's the Middle Eastern countries, because they've had a proactive attitude towards empowerment of female leaders, towards understanding the need for diversity in decision making. It's the Middle East that's blazing the trail, not the Western world. Is that something you'd agree with?
100%, 100%. And I have to say, even though I'm of Middle Eastern origin, because I was born and raised in the UK, I had that misconception that actually, if I was to move to a Middle Eastern country, I would have to act a certain way. I had the same misconceptions, and I have to say, I've been completely incorrect about those. And actually, the doors that are open to you, the female empowerment here, it's a very real thing. It's not just empty words. There's a mandate at the start of this year that every private company has to have a woman on its board of directors, and that's a very real thing. Private companies cannot function; they will be fined if they don't have a woman on their board of directors. So these sorts of things. The government has recently published a national policy on improving women's health, and this very quickly dissipates down to healthcare providers. We're told, how are you going to deliver on A, B, and C, for the national targets? And that's lovely to see, and it's fantastic to be part of this. And I have to say, if you've the wonderful thing about the UAE is, if you have that ambition, if you have that drive, just the possibilities for you are endless, and that's what's so exciting.
It is incredible, and it's interesting. I reflect on, as you remember, in January, somebody else who hopefully will be joining me on the podcast relatively soon, Dr. Ibtisam Al-Basaki from the Dubai Health Authority, who's been there for 24, 25 years, and was a real trailblazer for this, and actually privately told me some fairly shocking stories about the early part of her career. And some of the experience that she had as a woman coming into the system.
Yeah.
I think how important is it, not just in the UAE but globally, to remember that there are those women that were the trailblazers, that were the ones that came into the system and faced that level of adversity.
It's hugely important, Steve. I mean, it's still now in the UK faced, in other specialties a bit more. So specialties that are generally more male dominated, surgeons or orthopedic surgeons, they will face this more than others. So I have to say, as a female doctor, I'm not going to be alone in having experienced the general skepticism that some of my other female colleagues would have experienced. Yes, they are more common in certain specialties that are generally more male dominated, such as orthopedics, or general surgeons. What I think is important, for female doctors that have come through this, however, is not to think, well, I faced this, and to normalize it, but to remember actually, the difficulties that we face, talk about those obstacles, and to make sure that we keep doors open for those that are coming behind us. And that is something that I really, really place a lot of importance on. I'm not one of these fans that says because I've had a difficult time, then it has to be difficult for those coming after me. Let's just remember those coming behind us and keep the doors open for them.
How concerned are you about the global movements politically in terms of, there's been a lot spoken, and obviously the great Netflix drama that we've seen that focuses on the issue of male rage, political changes in the US and across Europe. As a woman in leadership, how much do these things concern you, and how do you think we can mitigate the potential effects of those issues?
Look, I'm not going to hide and say that some of the things that we've heard on the international stage from across the pond when I was in the UK, we say, haven't filled me with a little bit of anxiety. Some of the rhetoric coming out to me seems like, we've gone decades back, particularly those towards around diversity and equality. It is really concerning. I'm hoping it's all hot air, but we have to be mindful of those that will attach to that very quickly and ensure that the majority of the voices, the reasonable, the sound voices, are still there. We speak up. We are present and not hiding away, because at the moment it can be easier to hide away, as is always the case with bullies. But it's important to make sure that we represent in any area or any arena, any avenue that we have. Make sure that we represent the stable, the sound voices, and continue to educate the young, because they're going to need us there.
Mm-hmm. And there's an interesting point here, I think, and you may remember when we did the session in Dubai that I started by making the case and talking about the reason why I felt strongly about chairing that session. That some may have questioned a man chairing a session on women in leadership, but that there were issues for me around wanting to learn, wanting to understand. And I guess my question is, how can men who are sympathetic, who want to be advocates for women, who have that kind of reasonable viewpoint, how can we help? What can we do to support the female leadership agenda?
So exactly that, Steve, exactly what you're doing by being somebody who was happy enough to step up and chair a session on female empowerment. That's pretty brave, actually, and I think that's no, it is, and I think that's wonderful, and that's what it needs to be, because these conversations need to be two-way. They need to involve males. Needs to. So my husband will tell you he's the biggest supporter of females. He's got a very strong wife and a very strong daughter. So yes, so it's
As
important.
to be fair, have I? I've got two very strong daughters
Yeah.
and a very strong
So,
partner, so I know how that works.
I think it's important. We can't do this on our own, and we shouldn't do this on our own. So, because what we don't want to have is positive discrimination. We don't want to be in a workplace where it's just filled with women. That's not what it's about. It's about what the two genders can bring to, or all the genders can bring to the table, and the different perspectives. I think the future generation of healthcare leaders, they're going to be multilingual, not just in terms of language, but in perspective, and that's what's important.
Mm-hmm. And it's interesting, isn't it? I heard this comment the other day. Wouldn't it be nice to be in a world where instead of thinking about women's health, we were just thinking about health?
Absolutely.
How far away do you
Absolutely.
think we are from that?
Still some time, unfortunately. Still some time. And it's going to take a lot of us until we redefine, even at the moment, what women's health is, because it still continues to be about getting pregnant and delivering, and ignoring all the other aspects which are so important. So it's a work in progress, but there have been remarkable gains, and we mustn't knock that. We have to celebrate those successes, celebrate the wins, but keep our eye on the prize and keep continuing. And absolutely, like you said, we'll know we're there when we're talking about universal health, not women's health.
So where are the key areas in which we're behind in terms of the actual treatment, research, and understanding of women's health issues? We know there's definitely a huge disparity. What are the areas that we need to focus on lifting in terms of conditions, diseases, research, etc.?
Unfortunately, it's on almost all aspects we're behind. Even chronic conditions that you would think. So, for example, female cancers, we're far behind in the research for female cancers as compared to male cancers. Conditions such as heart disease for females, all of the education, all of the science, all of the research has been done primarily on male patients. The textbooks are all on male models. The training is all on male models. So even things that we think we know a lot about, heart disease, we know that, we've done that, we know what the risks are, but there's still training, there's still education that needs to be done. Even as simple as how a heart attack presents in a woman compared to a man.
I think it's important to understand the context around that. I mean, how different is male and female physiology? You know, these things like whether it's heart disease, cancer, etc. How different, or is it simply because we've not done the research? We don't know how differently these conditions will present between genders.
Well, we haven't done the research, but we know that male and female bodies are different. Um, but all the education, all the textbooks that I studied on were purely on male patients. Most of the cadavers that you trained on were male patients. There's no doubt that the physiology is different, and so we're now playing catch up. It is happening at speed, but we're still playing at catch up.
That is possibly the most bizarre and interesting example of sexual discrimination I have ever heard. You would have thought that men and women die at the same rate. So why would there be more male cadavers being used in medical schools than female ones? How does that even that almost doesn't compute, does it? How does that even work?
What's stranger, Steve, is that we never questioned it. We never we
Yeah,
and that's what surprises me now that I'm doing more work in this
yeah,
field. It's just, how did we not question that? Why did we not
yeah.
question that actually women don't present in this way, or that the study is differently? These things, we just took them at face value. This is how it was, and hopefully, as we have more and more people that actually question the status quo, this is when real change happens.
And also, quite bizarrely, who is it at the mortuary who's sitting there going, "Oh no, no, we'll send all the male dead bodies off to the medical schools, leave the female ones." And why? Why would you end up making that decision? I could go down a whole rabbit hole here, but I
Yeah,
won't.
yeah.
Instead, let's think about female-specific condition areas, because I think there's a really important point here that you mentioned earlier in the conversation, that a lot of the work, a lot of the money, a lot of the research that does go into female health goes into reproductive health specifically. What about menopause? Because that's the one that I think, again, as a liberal man, I sit there and I go, that's something that I don't understand. But then I talk to women who are in their 40s and 50s, who are quite scared of it, and equally they don't understand it. It's almost like it's been brushed under the carpet and forgotten about. What are we doing to understand the changes that the female body goes through in menopause, and what do we need to do?
So we need to do a huge amount. So, Steve, I'm embarrassed to tell you. So when I was studying obstetrics and gynecology at medical school, I think the menopause lecture was one slide in a
Wow.
lecture.
One slide, literally
Pretty
one
much,
slide.
where it's like, this is when your periods stop, and this is what the hormone levels would be. So there's a huge amount of education to physicians themselves, so that when patients finally go to access care, because they're like, this is not normal what I'm feeling. And we have to remember that menopause is becoming a real problem, because it's almost, we're victims of our own success. Well, medicine has improved so much that people are living longer. So people are living with menopause, or women are living with menopause a lot longer. So the problems that we're seeing from the menopause, very real problems, not just vanity of hot flushes or feeling hot, but actually cardiovascular issues, osteoporosis, very real medical issues. We when patients are, or women are able now to access and think, I need to go and get checked out, then the doctor they go and see actually knows about it as well and understands. So there's a lot of education, and I'm not talking about just general practitioners even. I'm talking about specialized women health doctors that need education on the menopause. One thing that I'm very excited about at Danat, actually, we've just done a collaboration with a company called Profam, where we are offering a very unique treatment called ovarian tissue cryopreservation. Now, it's not unique in that it's something that hasn't been done before. Ovarian tissue cryopreservation was done for women who had cancer, and it was done to preserve their fertility. Now, because we are looking at reproductive health in a much bigger scope, we thought, well, actually, if you preserve that ovarian tissue, it can be used to delay the menopause as well. And why is it only that we should preserve ovarian tissue just for women getting pregnant, but why can we not look at it to expand the scope and use it to delay the menopause? So we will be doing our first case next week, actually, and it'll be the first in the Middle East where we're doing ovarian tissue cryopreservation purely for delaying the menopause.
That's incredible. So what are the kind of numbers around that? Yeah, how long can it be? Can it delay it for? How does it
So
work?
it can delay the menopause for up to 8 to 10 years.
Wow, that's, I mean, the difference that would make to so many female lives, if you
Absolutely.
could actually apply that across the
Absolutely.
board, is incredible. It's amazing to hear.
And we have to remember that it's about just giving choices for women, empowering
Yeah.
women. There are women there that, firstly, they may go through the menopause early. So it's not about, appealing to women's vanity and trying to delay aging or anything like that. Some of these women genuinely will go through the menopause earlier, and so they need that protective effect of the hormones. Some women cannot take artificial hormones because of breast cancer risks in their family or for themselves, so on. So it's about giving women options that they don't have to suffer in silence. They can take charge of their own reproductive health needs, and that's really important. We can't have just a one option choice for women.
Is there a law of unintended consequence around this treatment, though? I mean, are you going to see women in their 50s wanting to have children because we've been able to delay the menopause and therefore they're able to remain fertile? And the dangers that go alongside that could be exponential.
Absolutely. As with anything, there's going to be ethics involved, and you picked up quite rightly on one, which is, at which point do we think it's in the best interest of that child to have an aging parent, because there are real risks that go along with being pregnant at both for the child and for the mother, actually, at a higher age group. But also there's ethics in terms of what happens if to that ovarian tissue should the person pass away. Who does that ovarian tissue belong to? So there's a lot of ethical concerns and considerations around it.
It's a fascinating topic. Coming back to the general issue around menopause, as we become more, I mean, I suppose the issue in the past has been misdiagnosis in menopause being a hugely nefarious issue. How have we improved in terms of our ability to diagnose menopause, as opposed to looking at it, expecting it as anxiety or misdiagnosing it as a different condition? Where are we in terms of understanding what menopause is and how it presents?
So I think we've got a lot better at diagnosing menopause. What we haven't got a lot better at is the management. And that's still a lot of education at the physicians, and this is what I was telling you. So we've managed to we've done a lot of education in terms of public health, so the patients know about it. They know that they can access doctors and they can push for a diagnosis. So that education has been really, I think, really solid. What we haven't achieved so well yet is the reciprocal side of it, where the doctor knows, okay, so I've got this patient with these symptoms. what options are there, and how do we tailor the management? It's not just give artificial or HRT, but there are other options, things like testosterone, looking at what symptoms that a person is presenting with, putting somebody on antidepressants or beta blockers if they're there's lots of things. It requires a much more tailored approach, and I don't think physicians still have enough knowledge on it. The misdiagnosis that we hear a lot about for women's health particularly is endometriosis. This is a real silent chronic problem where huge numbers of women are living in silence with the most horrific pain. And this is having a huge impact, not only just on women's health, but actually on the economy, because the amount of sick leave, days lost or women not even going into employment because of the pain that they're suffering. So this is the real big misdiagnosis that's affecting women's health.
It's a really interesting topic, and I'm really glad you brought it up, because endometriosis is, I mean, I used the word nefarious a moment ago. Endometriosis is horrible in a really, and I think there's a thing here, isn't there, because of the nature of what it is and how it presents, that actually, are women almost afraid to tell their employers or to actually turn around and say, this is something that I'm suffering from, because it's got a fairly unpleasant secondary name, hasn't it? Was it dry vagina? Was is that, have I got that correct?
No, so dry vagina is separate from that. It can be a
Oh, sorry, I
consequence,
got the
but
two
it's
mixed up. Yeah,
no. But it's. I think the stigma around endometriosis is that it's chronic.
yeah,
It's in your head. It's pain. It's never really going to go away because it's associated with your period. So if you've got
yeah.
a young employee who's got chronic pelvic pain in terms of she's got painful periods, she's going to be a problem for
Right.
me because she's going to have this every month. She'll tell me she has to go off every a week, every so often, every month, because she's got her painful periods. And so it's got a really bad stigma around it.
Yes. Actually, the vaginal dryness thing, I think, was something else that I was reading about around when women with menopause and serious conditions that come
Correct.
with
Yeah,
that.
that's
Because
right.
again,
Yes,
that, as I understand it, is enormously painful and very, very difficult to do.
absolutely.
Yeah.
Absolutely.
And I suppose all of this then leads into the kind of next piece of the puzzle, which is women's mental health, because there's a very different set of issues, problems, and circumstances about female mental health. Are we understanding the pressures and the strains and the stresses that women go through in their daily lives? And actually, are women, just because of the nature of the way in which our cultures have evolved, far more likely to just kind of get on with it without actually presenting with mental health issues? What are your thoughts there?
So, for women's mental health, it's a mixed bag for me, because I think there are times when I think we're ahead of the curve in terms of male mental health. Now, obviously, as the CEO of a women and children's hospital, my real big push is getting young males or adolescents to talk about male mental health. So there are times when I think we're ahead of the curve. Yes, the load on women's mental health is a lot, because there's lots of issues that they deal with. But I think there's an openness to talking about women's mental health that is less available for male mental health. Generally, women are less likely to complain. So I think they will put up with a lot of issues, and think this is just how I'm meant to feel after having a baby. This is how I'm meant to feel after I go through the menopause. So yes, there is a certain element in that women will put up with things, but I think there are more conversations around women's mental health, and that's because we're seeing an increase in female healthcare providers, female healthcare leaders. I've had patients here in the UAE who thought I'm a psychiatrist, actually, because when I'm talking to them, I'm giving them that full holistic approach. I ask them how they are. I'm not focusing purely on the problem that they come in with. And I think as you see more and more female healthcare providers that becomes a little bit easier because we can talk to one another, and women will have those avenues to talk to each other. So perhaps that's one thing where we're a little bit ahead in the game, because we talk about it and we have avenues to talk to each other about it.
It's a really interesting point that you raise, actually, because I mean, here we are on a podcast, and I think, you know, if you obviously, I'm not proposing that anybody should click off this podcast and go and look at any others. Certainly not until we finished our conversation, anyway. But there are, you know, there does seem to be it's a great example of social media doing good things, in the respect there does seem to be a much stronger supportive community of podcasts, of content available, of women supporting women in maybe a way in which, you know, the opposite is true in terms of some of that sort of toxic masculinity stuff that we were talking about earlier on. Correct. I want to go back to talking about you, though, and your career, because, of course, the other thing, tell us about the new role. So you're now involved in IVF for M42 as well. What does that consist of?
So my role is basically, rather than just being the CEO of the Women and Children's Hospital, it's women and children's care for all of M42. So it's taking that across other healthcare facilities that M42 has. And part of that is IVF facilities, but also looking to branch out into other areas. So at the moment we're based mainly in Abu Dhabi, but looking to reach and get that same healthcare that we're providing here, that trailblazing healthcare, a little bit further out. And that's what it's all about, is making sure that we've got accessible healthcare. So looking to branch out to other areas like Sharjah, Al Ain, and perhaps to Saudi, actually, because M42 has reached out to Saudi and Bahrain. So looking to kind of make sure that we've got think of it as the spokes of a wheel, but, you know, you've got the central part here and the spokes outwards. So we're sharing that excellence and that level of care, and making sure we've got accessible care for all.
So yeah, we're coming to the end of our time together today, unfortunately, which is a shame, because I think we could chat forever. But I guess where I want to finish here is in terms of thinking about, you know, the example that you've provided. Like I say, my own daughter watched our previous interaction and was inspired by it. You've obviously got your own child following in your footsteps. What are your messages to young women that are coming into either as patients experiencing the healthcare system, or women who want to pursue careers in healthcare? What are your messages? What are the things that you'd like to convey to them?
I would say be relentless, be proud, and be unapologetically ambitious. Women quite often feel, oh, I'm really sorry, I'm passionate about this, or just be unapologetically ambitious. The world needs your voice, it needs your vision, your care, and don't let anyone define your ceiling.
And definitely, given the basis at the very beginning of our conversation, don't put Summia in a box.
Yeah.
Summia, look, thank you so much for your time. It's been inspirational, revelatory, some fascinating conversations. And I'm looking forward to seeing you in Abu Dhabi very, very soon. Thank you so much.
Thank you so much. Thank you for inviting me.
And thank you all for watching another edition of Health Beats. There'll be another one along very soon, and I guarantee we'll have some more fantastic and interesting debate. If you haven't already subscribed, make sure you hit that subscribe button on Apple, on Spotify, wherever you're getting this podcast. We'll see you again soon. Thanks very much. Bye.